Hello. Today we're going to talk about how to get your GP practice CQC ready as a masterclass, and this is relevant for the year 2025-2026. Obviously, if it's after that time, many things will have stayed the same, but one or two things may have changed, so it is best to double check. And if you're wondering who I am or why I'm here to tell you this stuff, well, hopefully some of you know me from any of the training sessions that I've given over the years. But I am a practice manager, very recently retired, over several areas over the years. I'm also a trainer and mentor for the Lancashire Training Hub, the LMC, and for you Manchester practice managers under GP Excellence. I'm also a private consultant in estates, and I am dabbling with a little bit of locum practice management, actually including looking after a practice currently who has gone through a bit of a failure with their CQC and helping them through it, which has given me some great deal of information to help you with today. So our discussions today are briefly going to go over safeguarding, complaints, freedom to speak up, business continuity, health and safety, including some risk assessments, buildings, estates, sepsis awareness, policies, HR, digital, appraisals, significant events, staff awareness, leadership, and business and succession plans. All things that CQC are going to ask you about, and all things that you need to have an awareness of to make sure that everything goes smoothly on the day of your inspection. And why are we doing this? Why don't we just wait and see if CQC are actually going to turn up? Well, actually, because 2 weeks' notice is not enough to put things in place. You need to be ready at all times, so you don't need to panic when that call comes. We really need to hope for the best, but prepare for the worst. Something that you'll have probably heard me say if you've been on the business continuity talks, and something that business continuity plan does sit alongside your practice plans for getting your CQC ready. So you really need to have attended both training to make sure that you've got absolutely everything in place. We must start with safeguarding and CQC. But safeguarding isn't always everything that you might think about it. One thing that CQC look at is the safe recruitment process that's in place, including looking at the effective use of your DBS, your disclosure and barring service, as it should be dealt with in your DBS policy, making sure that you have got your correct DBS plans in place for all new starters. They look to see that clear lines of accountability exist within the organisation for safeguarding, and that all staff are aware of the safe whistleblowing process. They need to check that all staff understand the requirement to work in an open and transparent way. That means a duty of candour, admitting mistakes and saying you're wrong, not hiding things if things have gone wrong. You need to make sure that all patients are treated with dignity and respect, regardless of their culture, disability, gender, age, language, racial origin, religion, or sexuality. And that all staff adhere to the guidance in their handbook that is given with reference text to safeguarding. And that all staff effectively interact with the relevant agencies, sharing information appropriately, but not sharing things that aren't appropriate. And we talk about that when we look at information governance. And that all staff that work with children, young people, and adults at risk are responsible for their own actions and behaviour, and should avoid conduct that may lead to another responsible person to question their motivation or their intentions. So we need to really conduct ourselves in a professional manner at all times and make sure that our staff are doing exactly the same. So let's have a think about safeguarding and CQC with safe concerns about our patients. What do staff report about adults and about children's safeguarding? Who is the lead? And what level of training should you be covering? These are all things that you'll be asked about during any visit from CQC and checking to see that you have these things in place. You'll also be asked about Prevent Radicalisation, the government programme to help people who are at risk of becoming radicalised. There is a case study at gov.uk that you can have a look at and become more familiar. And your staff should know the National Prevent line and who to call. It's up there on the screen if you're unsure. So we need to think about our training levels. Training level 1, all our receptionists, our admin staff and secretarial staff, with the exception of managers or lead roles who may need level 2, should actually complete level 1 safeguarding. Also any volunteer staff. And our level 2 should be for our practice managers, our deputy managers and any other leadership role. Our care coordinators, our reception managers, our safeguarding admin, our managers or leads of administration and secretarial teams, our healthcare assistants and our pharmacy techs. And then when we get to our safeguarding level 3, that's all our clinicians, our GPs, practice nurses, physician associates, pharmacists, paramedics, any advanced nurse practitioners, social prescribers, mental health workers, physiotherapists, practice nurses, dietitians, all our clinical R's roles. And then if you have a specific PCN coordinator for safeguarding, they also need to do that level 3. And our GP trainees, although they will do that under lead employer and not under us. Our safeguarding lead needs to do further training, but there isn't a traditional level 4 training. But they need to do some actual additional parts, maybe some extra prevent training or to attend some conferences. And when they do that, they need to get their certificates and they will need this evidence of additional training to form part of their safeguarding lead's annual practice appraisal. And we need to think about our record keeping and how we're going to look at our safeguarding within our record to make sure it's all up to date, because CQC are not only going to ask our staff when you would report a safeguarding incident, they are also going to check and audit that safeguarding conferences are being coded into the records correctly and that safeguarding meetings are happening quarterly. Sensitive third-party information should be hidden so it cannot be read on the NHS app. And if you're dealing with multi-child case conferences, you need to redact the other names, because don't forget that's the part of their record for the rest of their life and they shouldn't have brothers and sisters' names in those records. So you may have to make several copies with different redaction and scan those in, unless you have any redacting assistance with digital stuff that will help you get those in and redacted within the record. And we need to go back and think about that slide where I said that CQC will be asking you, asking your staff, what will staff report? Adults, children, who is the lead and what levels of training? We've talked about the training, but they should know who their safeguarding lead is. Is it a doctor? Do you have a safeguarding admin as well? And they should be able to name both of them. Thinking about what they would report. This is a time where I would normally ask you and you would answer me, but we're on a video. So have a little think. With children, we think about bruising. We think about neglect. Are they hungry? Are they dressed scruffily and dirtily? But try and think a little bit outside the box. Often kids will get mud down themselves or a bit of food down themselves. They may get bruised because they've been playing in a rugby or football match. So we need to think about, is this unusual for them? Do they look rather than a bit muddy, but actually ingrained dirt? Then we start thinking about adults and think again outside the box. Are they suddenly appearing with somebody different coming in with them who seems to be a bit coercive and controlling? Is it somebody that you feel might be at in risk of domestic violence. Or perhaps a more unusual circumstance, somebody coming in without the ability to speak English and being managed almost by someone. Have they been brought in to work against their will? All sorts of things can be happening. And we let safeguarding know, because if we let safeguarding know, they will generally organise, check, meet with these people. You won't find out what's happened quite often, but things will start to happen. And if you have any concerns, share it with your team in a safeguarding meeting. Hopefully that information will have come through to your safeguarding admin and can be discussed at a meeting for all of your clinical professionals that attend that meeting, plus any outside staff that you may also have there, such as health visitors when you're discussing children, or social workers that may be invited. So keep that in mind when we're working through. There's so much to cover today, so it's only a short part on safeguarding. As very important as it is, we need to make sure that we move on because there's so many things to cover. The other part that CQC will always check on is your summarising and your Lloyd George records. Most of you will be digitalised by now, but think about those big bags of records that suddenly turn up from the undigitalised practice, or sometimes from Scottish or Welsh practices that are on a different system. And when these come in, you do need to make sure that at some point the records are summarised. But if you can't get them summarised straight away, you need to at least have a system. Get them scanned on so that at least any doctor can get hold of them. If they're not scanned on, you need to have a way of alerting the doctors that actually there is a paper record. That could be on your alert system, anything like that, but you need to make sure your policy is the same as what you're actually doing. And your Lloyd Georges need to be set in some way of order of arrival so that you know which order to summarise them. And this is something that CQC are actively checking on to make sure that this is happening. Any staff that are summarising should actually have real, correct training in coding, where they hold certificates to say they're capable of doing that. And there should be a leader who is auditing and checking their coding on a regular basis, and you can prove those audits have happened, showing teaching as required if the summarising hasn't been done quite correctly. It's really important you get this right because this is people's records forever. Another part that CQC will talk to you about is your staff training. Your mandatory training checks, that will include things like safeguarding, information governance, manual handling, life support, infection control. Plus there will be more role-specific training. So any staff that are doing something role-specific, make sure you have sign-off proof where people have been signed off doing things like phlebotomy, 10 of those bloods being checked and signed off by another nurse to make sure things are being done correctly. Make sure that's all available for CQC when they ask about it. A hot topic this year appears to be care navigation. If you're on total triage, this may be not necessary, but if you are using care navigation within your practice, you need to make sure that your staff actually have a certificate that they've had training in care navigation. Staff will also be asked about training opportunities for personal development. Is there something they've asked to do and then perhaps they've been told no? Have they been told no and given a reason why? Is there some kind of proof why they can't have that personal development? Or if they have been given the opportunity, make sure it's showcased to CQC. They're very interested in seeing and hearing about this. CQC will also look at complaints. So you need to make sure your complaints policy is up to date and followed every time. You can't have your staff saying, oh, it's one thing when we send it to the practice manager, but something different when the assistant manager's in charge. You need to follow the policy. Letters also have to contain where to go next, such as the ombudsman and how to do that. Probably a good idea to have a complaints pro forma or template that you need to complete that has all that information embedded into it so that you can make sure you're giving the correct information to people. Have a spreadsheet of complaints, or if you use something like TeamNet or Practice Index, you should be able to fill out their parts and pull that down for CQC. You will be asked to show this. Ensure it's detailed. Nothing should be hidden. Admit when you've made mistakes. Remember that duty of candor. It's really important. CQC will ask your staff what to do when somebody complains. What is the escalation? Who do they contact first? Your team will be asked, and your policy needs to reflect what your team think it is. So for instance, if all of your verbal or easier complaints or your non-clinical complaints run by your reception manager, but your clinical complaints maybe go to your assistant manager, make sure that's what the policy says. They will want to see that the policy is actually what you are doing, and that needs to work together. And do keep a log of verbal complaints, because this can be challenged by CQC. Be honest, be upfront with CQC about how your complaints go, and make sure things like any complaints leaflets are updated if new staff take over, particularly a new practice manager, because wrong names on there will get you in trouble. So make sure it's done correctly. Please be aware of who your freedom to speak up guardian is. Understand that your staff know how to contact them, and they need to have those details up. I would always suggest that you get the freedom to speak up guardian's name and contact details laminated on posters and put behind reception and in every room with teams in. You should have the ability to speak to a freedom to speak up guardian that is not a staff member at your practice. Often your local LMC will provide someone for that, or perhaps your PCM manager, but they have to have attended the proper freedom to speak up training. You can't just give that job to someone without training. Your whistleblowing and your freedom to speak up policies need to be in place. They're not exactly the same. They are similar, but they're not the same. So you need to make sure you have both policies in place and that they are available to staff and staff know where to find them. Hopefully some of you will have attended the business continuity training, and this is a training on its own. We can't cover all of that today, I'm afraid, but there is an ability to watch a video that has been made of the business continuity planning as well, if that's required and you haven't managed to attend a training session. You need to have a high quality plan that needs to be updated regularly. You need to have a relocation plan. Is that a branch surgery? Can you work from home? If you have a dispensary or a pharmacy in the building, there are separate rules to follow and they need to be in your business continuity plan. If you have agreements with local surgeries in your PCN or local village halls, are those agreements up to date? Have you discussed them recently? Can we make sure that you know what you're doing and you're fully aware that your business continuity is in place? I can't speak much more about this today because we are limited for time, but do ensure that you follow the business continuity training that is being put on for you. And do make sure that it includes your NHS England's guidance for emergency preparedness, resilience and response concerning chemical incidents, planning for the management of self-presenting patients in healthcare settings concerning terrorism. There is a template in the business continuity training that ensures that all of those things take place and that you have covered absolutely everything you need to cover. So if you're unsure about your business continuity plan, please contact GP Excellence and ask if you can see the template for the business continuity planning, and you can work with that to make sure that you have managed to get an up-to-date, good quality business continuity plan. And you do need to update it regularly, particularly with changes of staff or suppliers. And that does include changes in the ICB, because you will have ICB leads that are noted in there. Next important part that we need to think about is health and safety. One of the easiest things to check on is, do you have the correct health and safety poster up in each of your sites? Can be bought in somewhere like Amazon. Doesn't need to be any more than that, but it needs to be the most up-to-date one. And the name of the responsible person needs to be added on there. Do make sure that if you've taken over a new practice as the practice manager, that your name or the responsible person for health and safety is on there and not the previous practice manager. It is something CQC are looking at. Do make sure that when you do an induction for new people, you do cover health and safety in that induction briefing, including the fire risk and evacuation rules, so that they know exactly what to happen in a case of health and safety. There is a health and safety booklet, and we have provided one with the documents that are going to go with this training. You can link that on TeamNet into your induction policy or whatever, or practice index, whatever particularly you use, or send it attached to an email to any new starters so that they have an electronic copy of that. It's a useful document, and it really will show CQC that you care about health and safety and you are working a little further within that. Make sure that you're taking annual audits such as infection control audits and cleaning audits. If you use a cleaning company, they should be able to do these audits for you, but do make sure they are actually doing them. Just because it's no longer a pandemic, we need to also make sure we still have PPE available for staff. That's gloves and masks as appropriate. There should be regular hand washing technique audits, and they should be completed preferably by a nurse who can work with your reception team, etc., to make sure they know how to clean their hands as well, not just the clinical staff. Your curtains should, if you're using, as you should be, disposable curtains, so that they are dated correctly and that the guidance follows your policy. You don't have to have curtain changes in a set time according to CQC. You just need to follow your policy. So for instance, if your treatment rooms are changed every 6 months, but your consulting rooms where the curtains maybe aren't used as often are changed annually, make sure your policy says that, because if your policy is different to what's happening, that's what CQC will pull up. Make sure you've got the appropriate posters up, reminding you how to wash your hands and things like that. It's very important those posters are up, because that's a visual clue to CQC that you are following health and safety guidance. There is training on the bigger infection control training that you can send your nurses on, going over your waste bin and your sharps bin training. Make sure that you have some awareness of that and make sure you're using the correct bins. There are also new bin rules that have come in this year with things like food bins, food waste bins, and recycling. So make sure you're following the rules and you have all of those things available. Make sure that your fire training is sorted for everybody. Sometimes this can be quite a fun afternoon for your practice learning events, where you can get a local company in to do fire training with your staff and they get to squirt fire extinguishers. Think about your emergency lights, your fire wardens, and your annual equipment checks. And what is really important is that if you have multiple sites, that you've thought about that fire wardens should be available at every site. So you may need more fire wardens than you think you need. And then think about COSH. COSH is really important, and that every item should actually have a COSH risk assessment, but also a safety data sheet. Sometimes it's false economy to buy stuff from the local shop because it's on sale at the time, if you haven't got the correct safety data sheet for those own brands. If you use some of the bigger companies like Hillcroft or Dean or Williams to buy some of your products, you should be able, they should produce safety data sheets for each of their items for you. And it's probably one of the few things that I would suggest you have paper copies. You should have a grab and go paper folder full of your safety data sheets for all of your things like your washing up liquid or soap. And that should be available either in the cleaning cupboard or under the sink, depending on what you think is useful, but make sure people know. Every safety data sheet should also have a COSH risk assessment that sits alongside it to go through what the risk is, as well as the safety data, and make sure you get all of those up to date. And any new products that you bring in, make sure that you get both the safety data sheet and the cost risk assessment to sit alongside it. I'm often asked what risk assessments we need as a minimum in each practice. There's a lot, and they do need to be updated at least annually or whenever there's a change. We need to have a risk assessment for pregnant or disabled staff in the workplace. You need a car park safety if you have a car park. As we just discussed, all COSH items need to be risk assessed. A risk assessment on wheelchair use, fire escape, infection control, RIDDOR, workplace driving, lone working, and a risk assessment for all equipment. We need a risk assessment for our home visits, a violent patient risk assessment, stress at work, clinical waste, and bloodborne viruses. So do make sure you've got all those risk assessments in place. There are some really good templates out there available from some of the bigger companies like First Practice Management, Practice Index, any of those kind of places. They should be able to help you with a basic template, but then you need to work through it and personalize it to your particular workplace. Thinking about health and safety, we need to check dates on all medication in the surgery. Place that often gets missed is GP's bags or drawers within GP's consulting rooms. So do make sure they're checked and everything's in date. You need to make sure you have a prescription tracker, which will help you through to show that you know exactly where your prescriptions are at all times and that they can be locked away. There should be a robust system for meds management within your practice, and make sure that you can show that system to CQC and that everybody's working the same. We're now going to move on to estates, because this is a part that will often sit under the practice manager. You need to make sure you have a display energy certificate and that it is actually displayed. Your pack testing needs to be up to date and your calibration at every site, not just the main site. Your fire extinguisher and emergency light testing needs to be updated. Your fixed wire testing needs to be up to date. And your Legionella tests annually with a clear result for Legionella. If you're in a building with a lift, you need to make sure your Lola has been sorted and you've had your Lola tests done. There is a spreadsheet provided, or you may use something like TeamNet where you update all of these things. All your staff should know how to follow policies and complete audits on your estates and your buildings. You need to make sure your staff take regular breaks. And because it's a computer-based piece of work, you need to make sure that eye tests are provided and at least partially paid for, and you should have a policy about that. For your insurance reasons, you need to have public and employee liability and display those certificates out at each site. You need to have building insurance, legal insurance, and some of you may have data insurance. These are all things to be thought about. Sepsis was a real hot topic a few years ago, but they do still ask. So do make sure that all your staff know how to recognise the acutely unwell or deteriorating patient, and they understand and can recognise the signs of sepsis. Sepsis is the body's life-threatening response to infection, and it can be catastrophic if undetected and untreated, leading to tissue damage and multiple organ failure and death. They need to just be able to ask the question, could it be sepsis? And have some idea of what they're looking for. And it's on screen what they should be looking for. So make sure your staff have some awareness. Make sure that all your policies are available to your staff. They should know where to get those policies. And please make sure that when they're answering CQC, if they are unsure, they don't guess. They just say, I would ask my team leader. But all your policies should be in one place so they are available. There's no set rule or set place for them to be, but make sure they are all available to your staff. And when you update them, do look. Amazingly, only this year, so we're currently in 2025, CQC have not only found policies out there that say the CCG, and they've been gone for quite a few years now, but also policies that say PCT. Well, they finished in 2008, I think. They shouldn't have staff who have left details. You can't just update a date. You need to read it and make sure it's updated. Policies should be readily available for all staff, and all staff should know where to find them. Staff members should know if a policy is updated. So how do they know? Ask your team and work a way that you can figure that out. Follow your policy, make changes if you change things. For instance, if you make changes about when you're doing your curtain changes, as we mentioned earlier, make sure it's in your policy and your policy is updated, and anyone that should know does know. Your IG policy should mention data protection toolkit around your breaches, and make sure that there is something in there so that all your team understand about information governance. You need to ensure your privacy notices are updated on your website, and that your staff know that. They know where they are and they know what to tell CQC. A real big one this year for CQC has been that there mustn't be a mixture of digital and paper staff HR files. You should have one or the other. I would suggest you digitalize everything and have a file with several subsections. And in those, you need to have a checklist to make sure what is available, because CQC will ask. You have to have a photo ID within somebody's file. That can be a copy of their passport or their driving license. You need to have a VAC&IN sheet, a DBS, and an annual update. There is an annual update available within this training that you can work with your staff on. You need to have their confidentiality form signed, a copy of their contract, their references, or if you don't have references, for instance, if you've got a staff member that's been with you 30 years and things were different then, you must do a risk assessment for a lack of reference. If you have a DBS that has anything untoward on it, even if it was 20 or 30 years ago, you need to risk assess and have that sat alongside any DBS that they're asking to see, to make sure that you've shown that you have seen there is a potential risk, even if it's 30 years out of date, and you have assessed that risk to deem that that person is safe to work with you. They are actually asking to see signed induction sheets, so it's no good just ticking off that you've done an induction with someone, but they're asking to see that it's signed by the person to say that they have actually had that induction. So think about that if that's something you don't do currently. An induction should include health and safety, a look round the building, and fire planning, as well as extra things that are just maybe specific to their job. Something that was new for me was staff files need to have proof of an up-to-date GMC or NMC or a governing body piece of paper in there. I've always looked at this when someone starts, and I've always looked periodically, but I've never actually taken the time to print to prove that I am looking. But CQC are now asking you to get proof, which could be a print or a PDF print in their digital file. You have to annually checked GMC and NMC registration. As I say, this was a new one to me. So if you're not doing that already, then make sure that you do start to do that, because they are asking. They're checking appraisals, not just that they've happened, but they are detailed and up to date. They're checking that clinical competency or clinical supervision sheets sit by those as part of that appraisal. If you haven't got a formalised clinical supervision that's signed off, or clinical competency sheets, we have made some sheets available that you can use, and they will be as part of the package that comes out with this video. You should have end of probation meetings, and these should be signed off and in somebody's staff file. And you should be able to produce a list of staff appraisal due dates. That's often available on some of the HR packages that you might use. If not, a spreadsheet is fine. They do look for a DBS annual update, so make sure that you are doing that and checking with people. You don't necessarily have to keep getting new DBSs, but you certainly have to update and check back with your staff. And as we mentioned earlier, that risk assessment, if anything is on that DBS. Moving away from the HR, we need to think about significant events. You should have a log of your significant events. CQC will ask to see it. That can be in a format produced by someone like Practice Index or TeamNet, or you can make a spreadsheet. You also, if you have a dispensary, you should have a near miss log as well. CQC will not be impressed by you saying, we are so good, we never have significant events, or we never have a near miss in our dispensary. That is a massive red flag to them. There should always be significant events because it is learning, and that's where we learn from things. You also have to show that you have learned from it, you've made an action, and you've seen that through. New contractual requirements started in April 25 on safety reporting. And if you haven't managed to put that in place, there is an action plan that will also be provided to work through to ensure that you are up to date with that. There is a national patient safety team who has worked with NHS England teams to co-design what we need to do to improve safety events. And this is what we need to start doing. We need to join various websites that we need to update and upload our significant events to. And we need to review that data from those events, and we need to discuss them along with our PPG. This is a new thing that we need to be learning alongside our PPG and making sure that significant events are discussed with them. We do have to have patients who are working alongside us and do some training alongside us to work with these significant events under these new rules. So make sure that you have a read of the action plan. It's quite a big piece of work, and that we get those things in place to make sure that you are up to date if CQC check. And alongside our significant events, we need to show that we know what to do with data breaches. We need you to make sure that your staff understands the significance of a data breach, and that you use the data toolkit to understand what needs reporting to the ICO, if that's the case. Sometimes nothing needs reporting, but we do need to have that understanding that we are aware when something happens, that we know what to do. CQC are very interested at the moment in business and succession planning. You may be asked if you can see the business plan for your surgery. If you do show them your business plan, it should have some finances blocked out. They don't need to see how much money people are earning. But your business plan should include succession planning, planning what happens as time goes forward if somebody leaves or retires. And so your succession plan should show upskilling staff, protocols for all areas so someone else can take the work on with ease, and more than one person that is trained in each thing. There should be clinical and non-clinical succession planning. So I would suggest that if you have attended the succession planning training that's happening, this will give you a good start. But these are also being recorded so that you can add into that and make sure that you have got that additional video that you can watch to understand a little bit more how to do succession planning. There is also some training on writing a business plan. All of you should have a business plan because your surgery is a business. If you're unsure how to write a business plan, the training will be made available for you, and that training is going to be videoed with templates available. So you can go through and look at those videos and make yourself a good business plan and look at your succession planning within your surgery to make sure that there is a plan. Delegate to your staff and get everyone to write a protocol on every part of their job they do, and make it really an easy to follow one. Simplify it down as if you're teaching a child. or if it's about IT, as if you're teaching me, because I'm not great at that. Perhaps make it as easy as go to the button on the corner of the computer screen, click, third one down states such and such, you click that. Make it really, really simple in bullet point format to go through every single part of every policy or procedure they do, whether it's writing a referral, doing a 2-week wait, sending off an insurance form or a SARS. Everything, if everyone works the same, it means that if you have that hit by a bus scenario where somebody suddenly isn't returning to work, somebody else may not do it as fast, but can follow their policies and procedures because it's all in place for you. CQC would like to see that kind of level of planning. CQC will ask to see minutes from meetings, and they will want to see that those are sent out not just to the people who attended the meeting, but also those that should be aware. So for instance, if you've got a clinical meeting, every clinician should be able to see the notes from that meeting, even if it happens on a Thursday, which is their day off. It's important they read the minutes, or at least that you do the best you can to make sure they go out to them. CQC will look at those minutes, and sometimes they'll look in great detail. I know recently of a case where leadership was actually questioned because a leader, a practice manager, stated they weren't aware something was happening in the practice. But they were in a meeting, mentioned on the minutes that they were there when that was discussed. So that would suggest that they weren't listening or that they hadn't been at that meeting at all. So if you step out of a meeting and come back, do make sure you read the minutes and you're not going to get caught out. And finally, staff awareness. It's really important that your staff feel okay at any CQC inspection that comes in. They will be asked about whistleblowing. They'll be asked if they know how to do that and do they feel confident. They'll be asked about their health and well-being. Is there a health and well-being board? Do they know how to get outside help? There is some samples that will be sent out to you with this package that will help you get that in place. They will be asked about their practice learning training at afternoons. To make sure that they are learning in them and not just leaving the building. It's always a good idea to have done a CQC awareness for your team, even if you're not expecting an inspection at this time, to make sure they know what to do. A good quiz is always good to do with your team. You ask the questions and see what they know, and then they can go away and learn that. There is a quiz provided in here, but you can personalize that and make that your own. Ensure your team understands how important CQC is for their jobs, so they take it seriously. But do make it easy for your team. If you could have everything in one place so they can find things easily, such as TeamNet, Practice Index, or just your shared drive is really easily labelled up, then make sure that happens so that they only have one thing to remember. We go to the shared drive, or we go to TeamNet, rather than all different places for all different things. Your team will make or break your inspection. So really do give them the support they need, but make sure your partners give you the support you need to get you through this, because CQC is a big headache for everyone. But if you've planned ahead, you've got your health and safety up to date, your safeguarding meetings are happening regularly, and nobody has to fib them because things are working really well, your policies are all updated. And when you get that call, you can just worry about the 1 or 2 last minute bits to put in place and not all of this, because this should already be in place and ready for you. Thank you so much for your time today in listening to this video. Do make sure you've asked for the handouts and you've got all of those, because that will help you prepare and be ready. And thank you so much. It's been a pleasure helping you and talking you through today. Thank you and goodbye.